انا فقدت الساعه الديسبلاي شوف الشاشه شغاله اصلا بروجكت سابليكيت شغال اشتغل شغال بس كان سكرين بس الشاشه انا اوصل في الشاشه وانا قبل الفعل في اي بي لا لا، في اي بي في قاعة جديد بتاع توسعة. لا. الشكل مثل والله. Yes. نبلش سجل. شاب جراحة العظام في مستشفى مؤسس.
السلام عليكم يعطيكم العافية. Today I will present one of my published paper 2 years ago. It's about the pelvic fracture. It was published in a medical journal called Medinski Lancet Journal 2024 September. This article is talking about clinical outcome of surgically treated displaced acetabular fracture with central dislocation using combined anterior and medial plating. As all you know, regarding acetabulum, it is a complex structure, and the inverted Y column theory, which was described initially by Jode and Luternen in 1960, it is described the fundamental anatomical and mechanical structure of the acetabulum, which consists of two columns, anterior column, the anterior lip of the Y, which consists of the anterior half of the ilium, anterior wall, the pelvic brim, and the superior pubic ramus. The posterior lip of the Y, which is the posterior column, which consists of the greater and lesser sciatic notch, sciatic buttress, the ischial tuberosity, and the posterior wall of the acetabulum. The stem of the Y is the sciatic buttress, with the most important structure, stable structure, connecting the acetabulum with the sacroiliac joint. Regarding modern classification of acetabular fracture, which was stated by Luternen after revising his total operative cases around 582 cases. In 1980s, he put his standard classification for acetabular fracture, and he put 10 types, 5 elementary, as you know, anterior wall, anterior column, posterior wall, posterior column, and the transverse fracture. The associated fractures, which is a combination of such fractures, posterior wall, posterior column, posterior wall, posterior column, posterior wall, transverse, anterior column, posterior transverse, both column fracture, and T-shaped acetabular fracture. Sometimes in practice, we might face cases which cannot fit to this classification, which is sometimes it is occur, and it is a combination or complex injury. We might find some pattern of fractures not fitting this 10 types. In our study, why we did this study, why this problem is matter, because acetabular fractures is occurring usually in young patient. It is high energy trauma, like road traffic accidents or fall from height. It is an articular fractures, which is very important to manage, and it is a complex with a lot of soft tissue injury, because acetabulum is a deep structures and there's a lot of vital structures in the pelvic area which might be injured. Clinical challenges, it is an articular fracture, so articular reduction is very important. Any delay in the management of acetabular fracture usually might result in difficult reduction and fixation. And the selection of approach for a stable fracture is very important because we need good exposures and good reduction according to the fracture pattern, and we need to get safety of soft tissue because there is a lot of vital structures, nerve and vessels at the area of the pelvis, and we have to protect it during our approach. Our research question: does the surgical fixation using combined anterior and medial plating produce favorable clinical outcome in displaced acetabular fracture with central dislocation? The main aim of this study was to assess long-term clinical outcomes functionally according to score. As you know, HRCP score is a clinical scoring system for functional outcome, and depend of a lot. We'll talk about it later because a lot of variables are measuring in this score. We use this score for surgically treated displaced acetabular fractures by combined anterior and medial plating. Methods in our study: it was retrospective, single-centered surgical cohort study. The patients involved in this study there were 16 patients included. The period it is between 2013 2021. 7.8 years, and it was done by single surgeon. Setting, it was done in King Abdullah University Hospital. Our inclusion criteria was closed, centrally dislocated acetabular fractures with articular slip of more than 2 millimeters. Exclusion criteria was open fracture. In this study, we used standard imaging, radiographs, AB, oblique views, Jode views, and the lateral, the CT scan, 2D and 3D reconstruction. The classification used was Jode-Loternal system, as we mentioned, and the surgery was open reduction tear fixation using different surgical approach, Kocher-Langenbeck, ilioinguinal, or Stupa approach. Fixation was anterior reconstruction plates and medial quadrilateral buttress plates. Follow-up was with serial radiographs and final HRCP score. Our results initially, the males were 12, females 4 patients. The mean age was 35 years. Road traffic accident was presented in 13 out of 16 patients, and right-sided acetabulum was involved in 11 patients out of 16. Fracture pattern distribution: we have 5 transverse, 5 anterior column, 4 both column. These are associated. Transverse posterior wall 1 and T-shape 1. Functional outcome results and union. The mean HRCP score was 88.84 plus minus 7.6. 80% of the patients, this means that 12 patients have good to excellent functional outcome. 100% have solid union achieved, and 0% have poor HRCP score. Outcome was excellent in 8 patients, was good in 4 patients, fair in 3, and 0 poor outcome. Some clinical, some photos of cases involved in this study. This is 39 years old female. HRCP score was 97.5. Preoperative X-ray. This is T-shaped acetabular fracture. T-shaped acetabular fracture with central dislocation. And this is final follow-up X-ray at 7 months, managed with ilioinguinal approach, pelvic brim anterior plating with quadrilateral buttress plate. Second example, this is preoperative and 1 year post-op X-ray view for patients with HRCP score 87.1. It was a both column fracture fixed with ilioinguinal approach, anterior pelvic brim plating, quadrilateral plate. Third example, 16 years old female with the preoperative and 8 months post-operative X-rays. It was a transverse acetabular fracture and managed with ilioinguinal approach, 2 windows with push through the plates through the lateral window and medial window, the quadrilateral plate. Regarding results, complication, and safety signals, complication was reported as acceptable. We have 2 cases of superficial surgical site infection, saddle pulmonary BE, and death in 1 patient. Post-traumatic osteoarthritis in 1 patient, no osteonecrosis, no heterotropic ossification. So clinical interpretation, no non-union, no poor Harris Hip score, no reported osteonecrosis, and no heterotropic ossification. What do the results mean? Regarding function, mean Harris Hip score in the good range suggests many patients retained useful hip function after combined plating. Timing, most surgeries occurred within the first 2 weeks and all within 12 days. Early fixation associated with satisfactory reduction outcome. Comparison of the previous study, consistent with the prior literature, anatomical reduction is the major determinant of functional outcome, and early surgical intervention supported by others is showing better reduction function when fixation is not delayed. Strength and limitation of this study. Strength, it was long follow-up. Mean follow-up was 7.8 years, which is meaningful for functional outcome after a stapler fracture. Consistent technique, all cases were managed by same pelvic surgeon, reducing technical variability and clinically relevant outcome. Harris Hip score directly reflected pain and function recovery. Limitations, it was retrospective design, small group, only 16, and no control group.
Just go through.
Our conclusion from this study, early anatomical reduction and rigid fixation using combined anterior medial blades were associated with favorable long-term functional outcome in this small retrospective cohort. Implication for practice, combined anterior medial plating may be useful strategy for selected stapler fracture with central dislocation, especially when early surgery and accurate reductions are achievable. Implication for research, future studies should clarify design selections, compare surgical techniques, and use larger prospective cohort with consistent outcome reporting. Our key points, take-home messages. The injury is complex. Central dislocation create high-risk intra-articular fracture pattern. Quadrilateral blade is the critical medial buttress of the acetabulum. Reduction quality is central. Early anatomical reduction and stable fixations within 2 weeks is associated with better functional outcome. Outcome were encouraging. Combined anterior medial plating achieves 100% union with 100% good to excellent functional outcome. Evidence remains limited. Small retrospective cohort, no control group. Thank you very much.
في حد عنده سؤال؟ عندي سؤال. يعني you said earlier intervention, right? What do you mean by earlier intervention?
Early intervention, we have to diagnose stapler fracture as soon as possible. We have to operate upon in the first 2 weeks, because delay more than 2 weeks result in difficulty in reduction and financing. So reduction is the main important step in getting articular congruency and not to get post-traumatic degenerative osteoarthritis.
Supposedly, I see patients with a delayed presentation. What your options are? Usually go for over-reduction internal fixation.
Yes, I will go. The procedure will be difficult. The reduction and accuracy of reductions will be difficult, but it could be possible. Complication rate and osteoarthritis will be more.
you might consider arthroplasty in delayed presentation.
There is a rule for if the delay presentations after weeks or months, primary, you can do arthroplasty. You have to reconstruct a recovery.
So earlier intervention is associated with better results, right?
Functional results.
Thank you so much.
شكرا جزيلا. صدر الاسباب الفراكشرز. ذكرت في جملتك انه 16 في حاله فقط وهي كميه قليله. انا ما قلت مش قليله. بس نقدر نسال شنو شرط الاسباب الفراكشرز؟ هذا قليل لان الفراكشر نفسه قليل جدا. وبأيدك تماما فيما قلت. Most important is to extract the continuity in the jaw as soon as that's the main. صدق الحكايه للدكتور احمد كان تاكد جدا continuity راحت.
Our next lecture will be about post-traumatic hip reconstruction, total hip arthroplasty after acetabular fracture surgery by Dr. زياد الهدات مستشار جراحة العظام والنقاط بمستشفى الملك المؤسس، أستاذ مشارك في كلية الطب في جامعة العلوم والتكنولوجيا الأردنية.
يعني this topic might be a continuation of the previous lecture, which is discussing the total arthroplasty after prior acetabular fracture fixation. As you already know, it's a highly challenging reconstructive procedure. As mentioned earlier, this is still open reduction term fixation is the mainstay of treatment for displaced acetabular fractures. However, there is an overall risk, overall conversion rate for arthroplasty, which ranges from 13 to 23%. In some studies, it might reach up to 50%. There are multiple risk factors that will contribute to increased risk of the conversion for arthroplasty, including fracture pattern complexity. This reflects that the initial impact at the time of the initial injury, and this might be one of the most important factors that sometimes you can't undo or reverse this injury. In addition, the quality of surgical reduction. Dr. Ahmed mentioned it was a step of 2 millimeter articular step. If it's more than 4 millimeter, then the risk of post-traumatic arthritis is highly increased. The associated dislocation with hip dislocation with intra-articular loose bodies are another risk factors. Acetabular impaction and concurrent femoral hip impaction will increase the risk of osteoarthritis and avascular necrosis, and subsequently total hip. The need will rise for total hip replacement. In this patient, this patient, and I think he's like in his late 50s. He presented with severe right hip pain, and this is his X-ray. You can appreciate that this is already a complex injury, and the hip is subluxed, and there is an associated proximal femur. I'm not sure that we don't have previous images. However, this might have contributed to the increased risk of arthritis and avascular necrosis. So, he received total hip replacement as primary, you can see. Another patient, you can see that he had acetabular fracture. Again, reflects this complex injury. This is another patient, as already mentioned, that this usually are younger patients, and this patient presented with severe left hip pain and obviously post-traumatic osteoarthritis and element of avascular necrosis. Yeah, based on this picture, you can tell that the reduction, which is it might not be the fracture will not well reduced, and this might lead to chronic subluxation of the hip. This contributing again to increase the need for a total hip replacement. So, in order to understand and address the different challenges that might be encountered when performing hip arthroplasty in such patients, it's good to simplify to simplify these challenges and to address them as a triple threat. So you have to consider the soft tissue challenge, which involves that you are operating on a previous operated field with the risk of adhesions, scarring, the risk of neurovascular injury, mainly the risk of sciatic nerve injury. These challenges you have to keep in mind. When you assess another challenge might related to bone, in terms of that the anatomical landmarks will be distorted. This could be due to the original injury and based on the surgery, the previous surgery. So these will contribute to the difficulties. Regarding bone also, which is I think is a major determining factors in such fractures, is the bone loss, whether it is cavitary or segmental. So these factors need to be addressed in order to achieve better results. Now the hardware, since this is previously treated with open reduction tear fixation, the retained hardware, you might need to think of the choices that you need, whether to extract, whether to keep, or how to manage this. And this is, as you already know, removal of metal sometimes might be challenging. So in such complex surgery, and you have to be prepared for such removal applications. Despite all these challenges and difficulties, your goal should always be to establish a stable hip center, despite these host tissue destruction. So in order to understand these challenges, we're talking about if there is severe soft tissue scarring. This poses a risk which includes that might contribute to muscle avulsion, neurovascular laceration, and poor joint mobility. Now, with this excessive scarring, as simple the location and dislocation of the hip might increase the risk of complications because this scarred tissue. So this might contribute to post-operative complications, including fractures. Now, in order to address this issue, you have to consider extensile approaches. Since this is a revision surgery, you might need to extend and use extensile approaches to expose normal tissue before you go into the scar tissue. This will give you a guide to the normal position or normal anatomy. So if you start from normal and then you go towards the scar, this might be helpful. Now, the choice of approach is essential in such cases. It depends on the previous surgery. You might consider if there is posterior lateral approach, you might consider direct anterior approach for hip arthroplasty in order to avoid this scarring. It depends, you have to individualize your approach based on the patient characteristics. You have to keep subperiosteal dissection to peel the soft tissue. And I think of the ilium, with this presence of distorted anatomy and scar, if you keep subperiosteal, then most of the time you are safe. If you are on bone, you will feel safer to decrease the risk of neurovascular injury. Another strategy is to avoid dissecting directly into the area of the maximum scarring. So try to achieve or try to expose or do your incision through minimal, or at least start from the minimal scarring, from the least scarred area. Another challenge is the sciatic nerve vulnerability during this is a revision procedure. So in order to achieve, to prevent this complication, directly isolate and trace the nerve early if using a posterior window. So identification, one way to go to try to avoid the injury. It might not be easy all the time. It depends on your approach. My advice is you go, as we said, extensile approach, try to identify the normal and then go toward the toward the scarred area. You have to be careful about the position of the Homan retractors. Keep the knee flexed. This might contribute to decreased risk of injury of the sciatic nerve. Another challenge is how to deal with the retained internal fixation hardware. The risk will be if the metal interfering with your reaming or your approach, this might lead to destroyed reamers. There will be metal debris and subsequently prolonged operative times. How to deal with this? You might do selective removal. If you don't have to take the hardware, all of the hardware, unless this is interfering with your approach or causing a special problem. You might need, if the plate or if the metal is well fixed, then and it's not in the way, it's advised or it's recommended not to remove it and keep it in place. You have to always be prepared for difficult removal and prepare broken screw extraction set. In this patient, he presented with hip pain. One of the contributing factors, I think, that the screw is inside the joint. And there is some element of avascular necrosis. So in this, we have to do, again, you consider the approach, you have to go through the same approach because you need to remove remove at least some of the metal. This patient, I removed only one screw and then proceeded for hip replacement. This patient apparently, it's part of your planning. Apparently that this patient needs the removal of these plates because they will be in your way, so you can't ream the acetabulum. Definitely you have to remove these plates. This is associated risk with nerve injury and more complications. Obviously, heterotropic bone hole is very obvious. You can resect those interfering with your approach. The challenge is the loss of bony landmarks. That means if you lose the normal or the identification, if you misidentify the anatomical landmarks, this might lead to cup malpositioning, and this might result in impingement and dislocation and subsequent also osteolysis. Now, how to address this? You might try to rely strictly on the sciatic notch and obturator foramen. I mean, you have to identify those structures that are well defined, obvious, and less distorted. So again, start from normal, try to define normal and go to more distorted anatomy. You use true reaming, which means that you start with a small reamer and go upwards and try to achieve bleeding cancellous bone. Your aim will be, your first priority is to achieve line-to-line press fit, and you try to avoid over-reaming. This patient presented with right hip pain, and we were able, I mean, the metal was not in the way, we were able to hip replacement with press fit as if it is a primary, and we achieve good press fit, large hip, multiple screws in order to achieve better fixation. This is another patient who presented with hip pain, avascular necrosis. Again, in this situation, we were not able to achieve press fit, so we used cemented cup. Major challenges in operating in hip arthroplasty in patients with acetabular fractures previously treated with overexternal fixation is the deficient acetabular bone stock. What is the risk? This will lead to implant migration and catastrophic construct failure. How to address this? Use porous metals. Porous metals like tantalum, and this will lead to more bone ingrowth. So the bone will be more incorporated with the metal. This might lead more of biological healing. You might need to use structural bridges, which will try to address mainly the segmental defects and pelvic discontinuity, including roof reinforcement rings, anti-protrusio cages, cage cup hybrid construct, and sometimes 3D printed custom tri-flange cage. You might use also, I think it's also useful, you use the femoral head cancellous bone, if available, to pack the small, especially the cavitary defects. Another strategy to address this is to use multi-hole cups, and this will help you to achieve more screws and more of diversion, and this obviously increase the pull-out strength of this cup. This patient, he's 57, was involved in an RTA. He had a posterior wall, posterior column fracture. He was operated. There might be some delay in his operation, but you can see on the post-operative picture that the hip is still subluxed at least, and the femoral head, I'm not sure it could have some elements of avascular necrosis. However, it was not shown. So in this situation, and this patient presented, he had revision surgery. This like in February. That's the fracture was in this like this. He presented 2 months after the initial injury. So intraoperatively, you can see that the head is deformed. So this will indicate the need for hemiarthroplasty. For the total hip arthroplasty. We used anti-protrusio cage to fix the hip, the acetabular component, and you can see the immediate post-operative picture. And this X-ray like few months later. This surgery was done again in February in 2015. His routine follow-up image was like in April 2021, which means about 6 years after the initial surgery. You can obviously see that the medial migration of the cup. The patient was asymptomatic. So my advice was just to observe. However, he sought medical advice at other institutions, and he received this surgery. Okay. Now, what's his concern? And his concern that this medial migration of the cup might compress the adjacent neurovascular structures. but he received this surgery at an outside institution. This was August 2021. He was actually doing well. He got some early infection, but he was treated with antibiotics. And the patient continued to mobilizing, and he was in minimal pain until 2025 March. Then even after the second surgery, he had recurrent dislocations. So he got dislocated hip. So we tried close reduction. Actually, we tried maybe multiple times. Okay. So after counseling him, he's like, I think he's like in his late 60s now, and he had multiple comorbidities. So he was severely disabled, so he accepted the risk of surgery. So what we did is we just removed the second cup, and we kept him with this, with his old cup. This is double mobility. Double mobility might be recommended in such patients. It's supposed to decrease the risk of postoperative dislocation. This is X-ray is in 2016 actually. يعني هاي الشهر الماضي. I'm not sure this. أيوه بمشي. صهيب.
طب الشوارع مصروفة ها تمام.
So when I go one more back, this is about the retain if it's stable, the construct is stable, then you might leave it, and the patient is asymptomatic. So I think this is a good example. You don't have to always treat the X-ray and the imaging, right? Now, a quick comparison between a primary hip arthroplasty and post-stapler surgery total hip replacement. You can obviously see that the complications is as expected. Complications were expected to be higher, especially the risk of infection, maybe more than 10 times more. The post-operative dislocation rate is significantly higher. Okay. Again, the expected survival of the prosthesis is less compared with the primary hip arthroplasty. The risk of infection you have to evaluate to keep. You have to exclude infection before operating on such patients. This patient presented with this with hip pain, obviously, and she had history of infection that was treated with multiple debridements. I'm not sure what fracture was this before, but apparently the metal was removed, and she had a cement spacer, and the spacer is already fractured. Then she's like 40 years old. So after we followed her up, kept her on antibiotics, follow up with ESR, CRP, and I think they're normalized. Then we revised her with a primary hip replacement. In summary, I think these main recommendations start by thorough preoperative evaluation, including getting CT scan to evaluate the status of the head and assess the acetabulum and the deficiencies. We always try to rule out infection. ESR, CRP are very helpful. if there is any doubt, do some aspiration. Selective extraction, don't always try to remove the whole metal. It's unnecessary unless it is obstructing your way or interfering with your implants. Keep your revision options available, including multi-hole cups, augments, and extraction sets for the removal of the metal. Try to keep the knee flexed almost all the time when operating on such patients. Thank you.
سؤال؟
شكرا دكتور على هذه المحاضرة المهمة. لما تعمل ريفيجن وفرجتنا حالات كومبليكيتد كثير. لما تعمل ريفيجن وصور انفكشن شو نعمل بحال شو بتعمل؟
Infection it's post-operative or prosthetic infection. It depends whether it is early or late. In early stages you might do just IV antibiotics. But sometimes if this is late infection, you can do either a single procedure or two procedures. You remove the metal, which is two-stage, which is most of the time is recommended. You remove the metal spacer, and then after you are sure that the metal is and the infection is controlled, you go for revision. It is a lengthy time consuming, but you remove the metal spacer, and then after you are sure that the infection is eradicated, you go for another for hip replacement again. Another time. This is هو external fixation, and this usually is elderly who compliance with with any sort of external fixation, especially and you need to span the pelvis, and this is it's not it might not be as strong. You might usually it will be cumbersome for the patient. I'm not sure this is external fixation in such situations. Might be it's not a very great option. You might go for resection arthroplasty. I might prefer this over going through even multiple procedures. Usually these are multiple, elderly or with many comorbidities. So you might go for less aggressive external fixation. Fine, بس انا حتى اكس فيكس البلفس شغال pulled out. It's بالبيدياتريكس I might use it, but in most of the time this البنس will not hold. This is osteoporotic bone, بس تعمل اجرها هيك غالبا will pull out.
خلاص منها عملت تكون بعد
تثبيت بس هيك بدك تحط له بدك مع انفكشن depends. I think it will be based on individual characteristics of each patient. You might go for extraction and reimplantation. You might go for external fixation. You might go for even amputation.
Case of distribution.
Yes, so
Central distribution. Do 2 steps of swimming, then a reimplantation. Here, and we know there's a specific age, for example, the more than 60, 65, or age. So we should 2 steps possible.
2 steps.
Superbeam and steps.
Superbeam. 2 stages age. What do you mean by 2 stages?
You mean in geriatric or young? Young, I would say, it's geriatric, this occasion, primary total frequency, there is a rule. Do it primarily to fix and put to the intermediate. One session.
في standard fractures, it could be early and could be intermediate. It's most of the time could be late. Now we replace or fix, we might go few strategy. Now it's replace and fix. To replace, you might do, you fix the fracture and do hip replacement at the same time. So there is a role for such patients. As again, to really unable to achieve at least reduction. Sure.
He should be orif at the total hip or when mean this is stable. It should be stable.
It should be stable.
Because you can use a ring and you can make it a stable fixation.
You mean a no? Yeah, or if the
Total hip stable.
this is the recommendation. Replace and fix. Okay. So it should be stable. What's your aim fixation? Element to achieve, you might use plates, you might use something cages. To bridge the gap so it will be stable, especially if you new methods. You put together should be stable. Protected with which implies
Question is about between method. These cases of but you can be worried about bulging, doesn't that fix
respiration. يعني if removed this cage مثلا dislocated the acid accelerate this. And if you extract it, it might lead to just amplification. But yes, it's I think up to it's up. You can just leave it. long term it's long term complications. if there is no, it's not asymptomatic, you leave it. Removal of bitter, generally speaking, it's controversial. You might remove, you might leave upper limb. Usually I don't remove almost any metal in upper limb if it's not causing any problems. However, مثلا بالlower limbs I might go for removal. فيش fixed rules يعني.
بيحكوا any metal. If the lower should be removed below the age of 60.
60?
Yeah, 60.
60?
60.
60.
60.
Ah.
Should be removed.
lower.
لو يشيل 60% صحيح.
في هذا البيت 2000 شايف بس يعني يعني يكسب ربيعه لكن شايف صحيح
And timing. Very quick. بقول لك behavior. مع انك مش vascular line the head not touched the initial surgery. You go away from it. There are words about this. Yes. يعني هو and this fracture is there. The increased risk with dislocation. يعني هذول مثلا if you can dislocate it, not likely. The timing, I noticed again, I noticed some develop even rapidly within يعني زي هذه الطريق within صار عنده hip يعني close مثلا ناس fighting years طيب مثلا initial يعني يعني initial injury is not appreciated يعني إذا كان في impaction بالاستابولة يعني it's not it's impaction you can appreciate so you can be thinking about it. Surgery could be a complication of the surgery, especially this is a posterior approach. So yes, it's known that might increase the risk of avascular necrosis. So I'm not sure we can predict it easily at least.
يعطيكم العافية جميعا. حتى عندنا خيارين، يا نخلي النقاشات مفتوحة واحنا اليوم عاطلين على المغرب بعد عن المشاعر، تمام؟ او انه نختصر جزء من المحاضرات او نمشي مثلا شوي الوقت نحضر، يعني المحاضرات عددها كبير على اساس انه ما يصير التاخير، لانه احنا المفروض كان السيشن الاولى نخلص ثلاث، فهي شوي يعني نقاشات فيها زمان ترجع اللي هي المحاضره كثير فائده، بس يعني لو نحاول شوي انه هذا نقطه، النقطه الثانيه الغداء حيكون في مطعم اميه متى بنخلص نروح نتغدى. يعني نحن متوقعين كنا حتى الساعه نخلص على الثلاث، يعني نص ساعه تاخير مش مشكله. حاول
يعطيك العافية. Anterior versus posterior approach in established. Actually, I did this lecture to achieve a result to do anatomic reduction for the acetabular fracture عشان ما نوصلش للresults of osteoarthritis with complication post surgery. The core principle always posterior injuries, you go to posterior approach, anterior injuries, anterior approach, but sometimes you have some cases, debatable cases. First of all, we should identify the fracture type by using imaging and like X-ray and CT scan. We have a longitudinal classification. We have two major types of longitudinal classification, elementary fractures and associated fractures. I think for elementary, it's easy to know from which side to go, anterior or posterior. But always the debate, it's in associated fractures. Posterior wall, posterior column. I think you know where to go, but the other debate in the other types of associated fractures, like transverse posterior wall, T-shape, anterior with posterior hemitransverse, and both columns. Always there is a debate from which side to go. First of all, we should have a good imaging. Nowadays, due to availability in the CT scan in the ER, we don't have a good X-rays for the patient because always the residents, when they see some injuries in the acetabulum, always they do CT scan. Because in OR, you have just X-ray, you have a CR. We don't have in the country a CT scan in OR. So there is some points in the X-ray, you should know it before doing surgery. The roof arc measurement, it's important to measure it over anterior, posterior view, and oblique views. Even there is some signs of like bull sign and spore sign in oblique views. We should know it, and to know how is your reduction in OR, and also the Judith also views is important to make it before surgery. And still the CT is the golden standard of diagnosis and plan for management. To see if there's intra-articular loose bodies, intra-articular impaction, to know the direction of the fracture, if there is both column, if there is a transverse, or if there is anterior or posterior wall fracture. Treatment, as all of us we know, there is a conservative and operative management. The conservative major indications, there is a patient factors and fracture factors. The patient factor according to the physiological status of the patient, if he's stable or not, according comorbidities, according the soft tissue status, and according the late or early presentation of the patient. This is very important because always when we do reduction, we do indirect reduction for the acetabulum. In late presentation, it's very difficult. Sometimes, as was mentioned by Dr. Ahmed, it's difficult to do anatomical reduction. So late presentation, more than 3 weeks, I think to wait and to see what is the result. There is a chronic pain, or there is something intervention with his life activity, maybe you can go to the total hip arthroplasty. Second factors, fracture factors, if there is a step off more than 2 millimeter, there is a wall involvement, less than 2 millimeter, there is a wall involvement more than less than 20 or 30%, and stable hip, you can go for conservative management. The opposite factors, we go for operative management. Now, to know the approach, we should know in each approach what we can access in acetabulum. The Coker-Langenbeck approach, the posterior approach, we can access the dark brown area here. It's just a small area, posterior wall and part of posterior column. Sometimes, if you want to access the blue area, you need to do a greater trochanteric. If you want to go downward to the ischium, you need to do a quadratus femoris reflection. And if you want to do that, I think medial femoral circumflex artery, which you increase the risk of a vascular necrosis of the femoral hip. In this case, you see a lot of iatrogenic AVN of femoral head after posterior approach. But sometimes you feel that you did a wrong plan when you go posterior, but you cannot do anatomical reduction. So don't apply your plate, and you think that if you flip the patient anterior, you can do something because already you did the rigid fixation. Sometimes to do a greater trochanteric osteotomy, you flip the greater troch with the medial gluteus, with the gluteus medius, and you flip it anterior, you make a Z-plasty, you make surgical hip dislocation, and you can feel the anterior column with the anterior iliac spine, and you can feel the quadratus, the plate. This is actually, I think this is the lovely approach for associated fractures, modified stop approach. You can access, as you see here, the anterior wall, anterior column, quadrilateral area, and superior pubic ramus. And even you can feel the posterior column. And also, if you open external iliac window, you can access the iliac bone. This is one of the cases. I think this is according to the 3D, there is the injury there. It's mostly in the posterior part with the comminution in the posterior wall, and also there's a step off in the posterior column. There's intra-articular fragments. There is incomplete fracture in the anterior wall. I think you know, now it's easy to know your approach. You go from posterior approach, you apply 2 hook plates to maintain the reduction for the wall, and over those plates, a longer plate to fix the column. Now this is a hemitransverse fracture with the extension to the iliac crest. We apply it through simple modified stop approach. We apply 2 plates infrapectineal with long recon plate. This is more complicated fracture with 2 columns and comminution in the quadrilateral plate. Through modified stop approach, we did infrapectineal with a recon plate, and also using external iliac window, we fix the iliac crest. Anyone can give us a classification of this fracture, please? Residents. Yes? Transverse. This is transductal or juxtaductal? Juxta, this is mostly in the roof. This is, I think, transductal fracture. Could be there is a comminution downward, could be a T shape. Okay, I don't have the CT. Which approach you can go? Dr. Ahmed, شو رأيك?
Modified stop.
Modified stopper. Others?
Fine.
From where to start? Anterior.
Modified stop.
Always.
يعني احنا مش شايفين CT.
مو عشان هيك. بس sometimes the X-ray is giving you a big hint from where to start. وأنا بحس مرات بتوجهك أكثر من السي تي. السي تي بتوريك some details you don't want to see it. You know? it's helpful. بالضبط. والمشكلة السي تي ما عندكش بالعمليات، ما في عندك سي تي. هلا this was done by posterior approach. What do you think? Still not fixed. Do you think if you go from anterior approach?
يعني التور تاع الستابل يعني
Okay, with rigid fixation like this, with a posterior plate and 4-5 screws, do you think if you flip the patient from anterior, you can achieve a good reduction for the anterior column? This was reduced also from anterior side. Sometimes the metal is covering your. Sometimes it's covering. Almost actually, to take home message, in fact, always the posterior approach is a very narrow approach for me. I don't know for maybe Dr. Ahmed. It is a very limited. Maybe it's lovely for
and it's most approach used for to treat a stable fracture. This is
100%. 100%. But if you have associated fractures like anterior column, medialization. بالضبط.
Most of the fractures are
most common approach used.
Because the majority of the fracture, it's positive. But if you have a medialization, if you have anterior column fracture, I think to start anterior is much better than to start posterior, because the posterior approach is very narrow. You have a lot of soft tissue, you have a lot of complication, you have heterotopic ossification, you have sciatic nerve, you have medial femoral circumflex artery. It's okay, but even the anterior approach, I feel that the anterior approach is less easier than posterior approach if you have a good assistance and if you are expert stop approach. Okay, this is the gold standard. Yes, you can shoot a screw You can shoot a screw from the external neck window toward the posterior column. This is very easy. الله يعطيكم العافية. شكرا. Question? لا خلاص. Sorry.
دكتور طبعا زحماني استاذ مساعد في كليه الطب ومستشار جراحه العظام في مستشفى الدكتور.
زياد. لكن مش هون.
انا قريب من هذه شهور سنه قصه لا طبيعي بعدين ما بس مرة نشوف.
السلام عليكم ورحمة الله وبركاته. وأخيرا راح نغير موضوع البلفس، الناس غير محبين البلفيك فراكشرز. هذا سيدي يعني بسوي شورتنج السيرجري. شكرا لك. راح احكي عن percutaneous femoral shortening over a nail using side smashing osteotomy technique, which a technique I modified to perform shortening osteotomy. So lip length discrepancy is common. 1.5 centimeters usually needs no treatment. صح؟ No lengthening, no shortening. For 1.5 usually patients require treatment. So my experience, مش عارف إذا agree معايا, people don't like to use, or patients don't like to use the shoe lift. بالعادة إذا بتقول له إذا بكون 2 centimeters, always they insisted to perform surgery to equalize leg discrepancy. So في عندنا 3 surgical techniques for lip length equalizations in the literature. أول واحدة limb lengthening, limb shortening, epiphysiodesis. 3 طرق. Bone shortening. I will be talking about bone shortening. Bone shortening osteotomy was the first procedure developed to equalize leg length discrepancy. First bone shortening was described in 1906. Careful, first lengthening was done by Elizarov تقريبا 1951. فالfirst procedures to 81 راح على ايطاليا 86 راح ايطاليا بس Elizarov 51. Different surgical osteotomy techniques and devices for bone fixation have been suggested. حالات shortening. So first bone shortening was achieved using wires. They shortened the bone and they used 2 wires to fix the bone. 1965, they've developed a device that intramedullary saw that cuts the bone. هذا هو الديفايس intramedullary saw inserted into the medulla. So we do our cut, 2 cuts. So if we need 5 centimeters cuts, we do 2 cuts. Between them is 5 centimeters. The problem in this device, it's not available always. Plus it ends the bone. رقم 3, it may break inside the bone and no way you can get it out. So I developed a modified technique. Drill hole osteotomy technique to smash the bone over a nail. The main character of our modified techniques is avoiding the use of intramedullary saw. So first, before talking about the technique, I would like to explain how do I assess leg length discrepancy. So I use a long film X-ray. ما بستخدم اللي هو X-ray scanning, long bone technique, X-ray. So I raise the short limb
until the patient feels comfortable. هون مثلا بحطه 2 سنتيمتر في البداية. Do you feel good? No, I still need more. برضه بحطه 2 سنتيمتر. Do you feel good? بقول لك yes. إذا قال more بزيد. إذا قال too much بنقص 2 سنتيمتر. I do X-ray and I measure the distance between the top of the head to the top of the film, top of the head, top of the film, and I calculate the difference between them. هذا ايش بيساعدني ليش؟ So لو فرضنا 3 سنتيمتر على الرايت و 2 سنتيمتر على الليفت, so the difference between them is 1 centimeters. I add 1 centimeters to my 4 centimeters. By doing this, I can tell what is the exact leg length discrepancy. ليش أنا برفع على شو لازم أرفع I use I raise the shortened limb على left to decrease magnification. So the only area which is subjected to magnifications is from here. This is a small amount. هاي 5 centimeter 4 centimeters which raised up is not subjected to any magnifications, I'm sorry. So the only error I have راح يكون just in this اللي هي between the top of the hips to the top of the film. So after I measure the amount of shortening, so for example, I need 5 centimeters shorter. I insert 2 wires between the 5 centimeters on A or C, D. Then I drill the bone over these wires using cannulated drill. I do many holes, like a bone. After this, I ream the bone. It's important to do holes before reaming. لأن إذا عملنا على reaming on closed bone راح يكون عندنا high risk of اللي هو fat embolism. After that, I insert nail. I lock the nail proximally, just proximally, and I use the acetone to smash the bone inside. After this, اللي هو آخر واحدة, my assistant, I hold the limb, الfoot, I hold the limb. The assistant is hitting the nail against me to shorten the bone. After I shorten the bone, I lock the nail distally. هذا summary of the technique. رقم 1, wires, multiple holes, reaming, smashing, then locking the nail. So it's minimal invasive. هاي هون عندي هذا بس small incision. I just use this small incision to insert the nail once, not more than 2 centimeters. هاي الهولز for هاي الnail locking. هاي 2 holes اللي فوق for bone smashing. Indication. So patients who seek prompt return to normal activity. احنا بنعرف ان bone lengthening is a lengthy process. تقريبا you have to put the external fixator more than 6 months, 7 months. So if you like, so this technique gives quicker recovery or shorter rehabilitation period. هذا approach is recommended for patients who don't like to have the scars of lengthening, right? No, because external fixators leaves ugly scars on the skin. رقم 3, it may be the only method to equalize leg length discrepancy in obese patients. تعرف واحد وزنه 150 كيلو 130 كيلو, no way you can put an external fixator. So this is the only way اللي هو method to equalize them. رقم 4, مرات we combine shortening osteotomy with lengthening إذا في عندنا big discrepancies, for example 15 centimeters. We all agree no way we can lengthen 15 centimeters. So we shorten one limb, we lengthen the other limb. رقم 5, which is important maybe for tall stature, shortening. Some people who are, or some patients complain they are too tall. مثلا بنت طولها 101 shorten. Girls who are 191. You can shorten both limbs together. Well, good thing, they're allowed to bear weight immediately. So if you use a plate, the plate type, big incision, big muscle damage, and it's unstable. No way, بعد إذا بتعمل bilateral shortening, no way this patient can walk immediately after surgery. So by doing this technique, patient is allowed immediately to walk after surgery. Complications. بجوز أول واحدة the potential alteration of the shape of proximal femur. تعرفوا إحنا our osteotomy I do it in the proximal femur. ليش إذا proximal femur? Not to weaken the muscles. لأنه not to weaken the quadriceps. So we our segment which is taken out has to be far away from the muscle bulk. So the segment is shortened segment is proximal. هذا الشيء ممكن يؤدي to change the shape of the proximal femur, which has to be considered in future arthroplasty. Other concern is muscle weakness. It's important not to shorten more than 6 centimeters, because if you shorten more 6 centimeters, you will 100% end with weakness, which is no way can be treated. الحل bone lengthening بهيك حالات. عشان مرت علي حالة they shorten أكثر من حالة 6 centimeters أو صار معه shortening. حتى الفيزيوثيرابي والexercises are not helpful in these cases. So we published this case. هذا at that time بال 19 we had 6 cases. للأمانة we didn't have any complications. No patients was shortened more than 5 centimeters. Weakness we did it برضه none of them developed اللي هو quadriceps weakness. سلامتكم. تفضل.
دكتور رامي شكرا يعطيك العافيه.
الله يعافيك.
احنا من طبيعه البشريه واحد فينا ضاع فينا بنحب ننضوى ما بنحب نكسر الا في استثناء كم واحد ممكن ما شاء الله ما حدا يعمل شورتنج هو لما اكتشفوا الإصابة عندك أول عمل شورتنج بعدين بلش الرينج بعدين بصير في عندك كومبليكيشن بالنيرف فاسكولار لما نفوق 6 سنتيمتر اي ثينك انه بصير وشكل الفخذ بصير غير سياحي. بعدين حكيت انه 140 150 كيلو ما في داعي لا تطول ولا تقصره خليه ينقص بس. اما التقويم باعتقادي وانت معلم بالتقويم
الله يحفظك. لا والله في ناس بتطلب انها تكسر لا والله في ناس بتجي 170 مش عاجبه طول بتكسر. لا بس دكتور عفوا في ناس ما ما بحب اني احط الاكسترنال فيكسيترز. انا اول عمليه عملتها لبنت واحده صبيه لما شافت شورت لما شافت السكارز والازاره رفضت نهائيا. اقترحنا عليها ريسايس هي بطلة الأردن في السباحة عندها ذهبية وكانت أولمبيست. وقتها راحت دبرت عفوا بس كان في مشاكل كانت ريسايس في أول فاقترحنا عليها نعملها شورتنج استيوتنج. شي از فيري هابي. أنا كثير بعمل شورت. لا الناس ما بتحب تعطل حالها 5 أشهر و6 أشهر و7 أشهر حتى كمان. بالعكس هذا واحد طوله 175 صار أقول لك صار 171 أحسن له ما يعطل حاله تقريبا 6 أشهر في سنة فيكسيتر
مش دائما
6 أشهر. بالإضافة سيدي كلامك صحيح يعني كلام الاثنين صحيح. هي after all this is what an informed consent is. You sit with the patient, you explain options, whatever suits the patient more for his lifestyle, for his demographic, what he's looking for. At the end, shortening is an option, lengthening is an option. Shortening in some cases is much more better option for the patient, for his needs, for what he's expecting. sometimes it's the lengthening. So after all,
So, patient
yes, I
choice.
will do
Yeah.
both.
Yeah, patient choice.
Yes.
I offer both choice for them.
Yes.
هو يعني هو حط شوي قواعد للتطوير التنسيقي. يقول ممنوع نطول او نقصر اكثر من 20 سيجمنت اوف
صحيح.
يعني بالحقهم نصل
صحيح.
هذا هو الشغله الثانيه الاساسيات يعني حتى باثولوجيكال بوينت اذا في عندي قصر او طول في مكان معين the best thing حتى ارجع الاناتوميكال بوزيشن الفيزيولوجيكال اطول او اقصر المكان اللي اصلا هو قصر او طويل. الاوبشن انت لما تعمل دكتور يعني الطفل مثلا كان عامل فراكشر وطولت رجله بعيده 100% على تقصير الجزء اللي كان مصاب. اما اذا انا في عندي مريض صار في عنده شورتنج نتيجه فراكشر في جهه معينه، ليش انا اقصر الجهه الثانيه؟ ليش ما هو مش المريض مش دائما حكيم. احنا نطلب هو عنده صار قصر بون واخذ كل السيجمنت اللي قصر بونز مع المسلز مع النيرز مع مع انه احنا نقدر نطول الجهه
خلاص نتركها للناس البنات الطوال 191 سم. نتركها للبنات اللي طول 191 سم.
بعد ال 190
بيجوا لي هو 190 تتزوج علبك 190 شوي نتركها لها. ما عمري مثل التيبيا والله، بس التيبيا تستحمل اكثر من 4 سم. وصراحه التيبيا بجوز شوي صعبه مش سهله الان. ما جربت بدك تصير فيبولا وبعدين كويس بالفيمر انه الاسمس ينسيرت بتصير رجل اسمس، اما التيبيا المشكله انها بتصير تلف. صحيح ما جربت. هسا هو الكتب تكتب 5 للامانه. انا ما عملت اكثر من 5.
شو
اوكي في ليج ديسكريبانسي واحد فوق ال 1.7 بالعاده 1.7. هسه 1.7 في عندنا اوبشن زي ما بتعرف، اما يحط شورت اما يعمل شورتنج واما يعمل لينك. بس تجربتي مع العالم ولا واحد بيستخدم شورت، بيعتبروا انه هذا الباثولوجي الصغير حتى لو 2 سم ونص بزبط للاطفال. الفيزيوليسيس بزبط للاطفال.
سمعت بعد ما تكسر
صحيح بضل مكانه. بس في سؤال ضل محله. change shape of the femur للامانه 6 هذول احنا اكثر من 2016 في بنت وحده انه الشيب عندي شوي في عندي ديفرنس بالشيب، بس هي بتشعر فيه always it is unnoticed absolutely is unnoticed. بس تعرف انت 2-3 كيلو هيك اكيد ضلت تشكيله هي نفس البنطلون ما بينش لانه في بالعاده انا والله مش جد كيسات بالعاده يعني سواء 1 سنتيمتر من السيرفس مش انه بلكي لا في صوت لا هيدن عليك سنين بدون انا بمسك هيك هذاك بكون شاكوش مرسوم عليه 100%. فهو بضرب لا ببين معي الاطلاق يعني ببين معي الاكس راي. انا بمسك هيك اجينست هيم حتى لو ضل شوي مع ضربه الشاكوش على اللوك 2 بس تضحك تحسه طبقت على بعضها حتى لو ضل فراغ 1 سنتيمتر. لان هذا الجو مونوغراف مش مثل السود. فيش داعي ليش تفتح عليه؟ صراحه فيش داعي فيش داعي صار بطلعها من خلفيه صغار.
دكتور صهيب بن عيسى استشاري جراحة العظام في مستشفى الملك المؤسس واستاذ مساعد في كلية الطب والعلوم والتكنولوجيا الإسلامية بالدكتور about impact surgical science mortality and personal outcome in epidemiologic fracture patients.
Plus it was. I think that was. So happens.
So back to the basics actually. I'm not a surgeon, but ما فيش ولا مناوبة تقريبا تمر اللي بتشوف حالة hip fracture. So this is one of the early studies that I've done in my career. I want to look at the impact of the surgical timing on the mortality and functional outcomes in elderly patients with hip fracture. To know the so to know the scale of our problem, there are reported 10 to 14 million cases of hip fracture worldwide annually. The majority of these cases will occur in patients over 65 years old with multiple comorbidities. They have a very high one-year mortality rate, up to 30% of cases. I don't know if they have any national registry about these cases. And maybe we just start thinking about this because our population is getting older. Our life expectancy is getting better, let's say it. And we are going to face these cases more and more. With each hip fracture, you will face this controversy. Shall I operate early on or delay the surgery until I have the medical optimization of my patient? The proponents of early surgery will tell you that you will lower the immobility-related morbidity, which is a very major
problem with these patients. You will also lower the thromboembolic risk. Your patient will stay less in the hospital, and you will have a better overall functional recovery. On the other hand, the delay proponents will suggest that these patients are poorly managed if you go to operate very early, because they all need some sort of medical optimization. Some or a lot of them will have an anticoagulation medication that you need to reverse, and they have some cardiac and renal problems that need to be stabilized before you operate. So there are no general or global rigid consensus about when to operate, but in the United States and Canada, there is a guideline of operate before 48 hours. In the United Kingdom, recently it is 36 hours.
يعني لما تحكي early ولate,
We'll talk about
it's all agreed on انه it should be as early as possible.
No.
وهو يعني تحكي عن مثلا 1 week.
لا.
هذا تحكي time قديش واليومين لما تحكي يعني هاي معناها important يعني لما تحكي early delayed time frame يعني بس ما فيش
على 100%.
احنا اسبوعين احنا نحكي عن
بس
I understand يعني it's agreed on انه it should be done as soon as possible at least.
ما
يعني
ايش عشان في ناس بيقول لك 40 ساعه لازم قبل. لا اللي بيحكوا delay until you have medical optimization whatever is the date.
هذا سؤال.
You need to optimize your patient. This is the issue. I agree. Okay, so the big question is, does the delay itself drive mortality, or is it just a reflection that these patients are sicker and they need more optimization? It's not an actual cause of mortality. So this is the question we wanted to answer in this study. So this is a retrospective study about the surgical timing impact on mortality and functional outcomes with 3 key questions in mind. Does the delay more than 3 days independently increase the 1-year mortality? Is this increment, if it is there, a true one, or just there are more modifiable or more confounding factors that due to morbidity, other comorbidities, they modify this burden will modify this relationship, and what systemic factors that we need to target to prevent this delay. So it is a retrospective study in our hospital with patients with more than 50 years old with femoral neck or intertrochanteric or subtrochanteric fracture, or were operated with either fixation or hemiarthroplasty. We proposed the 3 days cutoff point. We went pragmatic, actually, and a lot of our patients are referred from somewhere else with multiple comorbidities. If you're going to operate on them within 48 hours goal, is sometimes not that realistic with our set of patients. The other thing is that some of the patients were operated during the pandemic, which put a huge risk or huge demand on our resources. So it was not that quick to operate usually. So the primary outcome was to measure a 1-year mortality. Secondary outcomes to measure hospital length of stay, ambulation within 3 months, ICU admission, blood transfusion, and readmission and revision rates. We ended up with 236 patients, 161 patient with the early group, and 75% with the delayed group. If you look at this comparison table between the 2 groups, you think that there are some differences but actually they are well matched because neither of these differences is statistically significant. If you look at the p-value, it is always above 0.05. The significant differences were in the preoperative variables were preoperative admission, which is much higher in the delayed group, and the preoperative hemoglobin. Not that difference, but it will reflect that these patients' reserve is limited, and they were just doing fine. But if you operate on them or they have fractures, they will deteriorate very quickly. They were more frail in the delayed group. They used to use walker or cane pre-injury. The operative variables were almost the same. About 3/4 of the patients received intramedullary nailing, while the other quarter received the hemiarthroplasty. And the operation type was comparable between two groups. The primary outcome, which is 1-year mortality rate, was 12% in the early surgery, while it was 31% in the delayed surgery. And this was a significant, statistically significant difference. Okay. Now, if this is real cause or not, we did a logistic regression analysis to see is this independent of the comorbidities or not. Our reference group was the early age group who had 1 or 2 comorbidities. And if you compare this group with the early group who have 3 or more comorbidities, there is an increase by 3.2. The risk will increase by 3.2 times. But this is, again, not significant. Look at the p-value. It is 0.29. However, if you wait for these patients who have more than 3 comorbidities and you operate on them after 3 days, the risk will increase and again by 3 times. So they will be in this age group, so 9 times worse. The most striking difference, you need to think about it when you see any patient with hip fractures, is this one. If you look at the early age group with less than 2 comorbidities and compare it with the same matched group who, have less than 3 comorbidities, 1 or 2 comorbidities, and you operate on them after 3 days, the risk will increase 13 times. So you think that these patients are resilient, they will be okay if you wait on them. This is not the case. You need to operate on them as soon as you can. So this is the most important difference I see in this study. The differences actually go beyond mortality. If you look at hospital stay, it is increased by 2 times. ICU admissions increased by 2 times. At 3 months, the ambulatory cases will be 3 times more, and blood transfusion is much more. All of these are statistically significant. At 3 months, about 1/3 of the patients in the delayed group will be non-ambulatory, and this will put a huge pressure on the resources. Each 1-day stay will cause the system about $3,000 to $4,000. And if you reduce the delay by 1 day, you will save 1.2 to 2.4 million annually for each 1,000 patients. So why does the delay increase mortality? It's almost all of them are related to immobility. the systemic inflammation, the thromboembolic risks, the pulmonary complications, the muscle catabolism, all will increase with immobilization. And if you keep your patients more in the hospital, they will catch some sort of infection. Anemia and frailty, they already have the lower preoperative HP level. So this will reflect untreated bleeding or nutritional depletion. But these are the main causes of mortality, which stem almost all of them to immobility. What are the clinical implications and recommendation? First one is that you can't act alone. You need multidisciplinary team. The most important of these is the anesthesia team, as Dr. Ziad mentioned. They will determine how quick you are operating. And you have to have some sort of agreement with them, because if they don't help you, it's not going to work. The other thing is that it is a multi-staff problem. You need everybody in the system to work with you, starting from the ER staff to the operating theater and the post-operative physiotherapists. Rapid anticoagulation reversal. You need to start anticoagulation as you can. Sometimes in the ER, you give them fresh frozen plasma, vitamin K, whatever you find appropriate. Treat the anemia, as this is one of the major causes of morbidity and mortality. You need to mobilize your patients as quick as you can. Every day of physiotherapy post-operative will decrease the complications and institutionalization. This one is very important, but I don't know if it is applicable or not. You need to pay people for their contribution in this quick response. And if you pay them more, they will have more reduction in the mortality. Avoid unnecessary delays. This study even resulted in that even healthier patients will have 13 times mortality with delay. So a take-home message: surgery delay independently doubles 1 year mortality, regardless of the comorbidities. Early surgery effectively neutralizes this comorbidity-related mortality risk. Even healthier patients will face higher mortality if delayed. Systemic barriers like ICU admissions and anemia are modifiable, and you must target them. A multidisciplinary approach is needed, and you need to reverse the anticoagulation as soon as you can. Timely surgery is not just best practice, it is a moral duty to this vulnerable population. Thank you very much.
يعني استمتع في اسئله جدا اذا في اسئله تستفيد على التايم بتسيس الدكتور حمدي النقرس، هو مستشار جراحة الجراحة اللي هو مشهور تطويل وتعديل التشوهات في مستشفى ابن الديف. تفضل.
شكرا دكتور زياد. أول شيء اسمحوا لي باسمي
وكنائب رئيس جمعية جراحي العظام الأردنية نشكر عطوفة الدكتور أيمن مصطفى على تنظيم هذا اليوم العلمي الرائع اللي خلانا نشوف بعض الزملاء من جيلنا والجيل الجديد. دكتور أيمن، رجعتنا قبل 20 سنة لما اشتغلنا أنا وياك. أنا للأسف في صور كثير معك، أنت شباب الآن بس لما كنت شباب في صور كثير في صور كثيرة بس للأسف ما حطيتهم. وكانت فعلا يعني فرصة رائعة إنه أنا كنت طبيب شراء خدمات بالخدمات، ولليوم بعتز بهاي الفترة اللي كل الناس حاضنة فيها. احنا اليوم خلص ابلش. احنا اليوم بنحكي عن اللي هو المانجمنت نون يونيون. احنا بنحكي عن جراحات البناء العظمي. جراحات البناء العظمي مثل اي تخصص فرعي في جراحة العظام، مثل السباين، السبورت، الهاند سيرجري، الارتوبلاسيا، التيومر. شو فكرتها هي؟ مثل ما حكى إليزارف، كونه من نحكي عن هاي الميثود، إليزارف بقول إنه إحنا بدنا نعوض الأنسجة التالفة، الأنسجة القديمة بأنسجة جديدة، ونستعملها في حالات التطويل، نستعملها في حالات التيومر. أحيانا بنشيل جزء كبير من العظم بدك تعوضه، ما بتخليه مثل هيك. في حالات الالتهابات العظم الصليدية الشديدة أحيانا بدك تعمل نيكروسيكوستروكتومية وتشيل جزء كبير، ما بدك تخليه يعني فاضي. في حالات الديفورماتي. فإحنا كوننا بدنا نحكي عن هاي الطريقة. إليزارف هو مثل ما حكى الدكتور رامي، هو انولد. مين منكم عفوا شارك في عمليات إليزارف موجودين؟ أو شاف أو شاف ما شاء الله كثار. احنا على فكرة يعني ادخلنا الأردن في جمعية الأسامي، اللي هي الجمعية اللي بتشتغل بالاكسترنال فيكسيتر. الاكسترنال اللي هو المعني إليزارف. هذول يعني هي جمعية عالمية بتعني بالإليزارف، وموجودة في كل البلاد العربية. طريقة إليزارف انتشرت حتى في أمريكا. أمريكا قديش كان لهم الاشتراكية وكونه إليزارف روسي، لكن بيستعملوا هاي الطريقة عندهم كثير. هذا هو إليزارف. طبعا مات وعمره 71 سنة. We refer the beginning of transversus osteosynthesis to 1951. مثل ما قلنا إليزارف offered his original apparatus and the technique of bone union. This gave a start to a new scientific and practical trend in traumatology and orthopedics. The appearance of one or another fixator not a new idea. احنا في عندنا اليوم اكثر من 300 نوع جهاز خارجي, but no one fixator became as popular as Elizarov apparatus. The Elizarov method uses Elizarov principle of compression destruction osteogenesis. This refers to the induction of a new bone between bone surfaces. بدنا نختصر. At Kurgan اللي هي مدينة في سيبيريا. At Kurgan developed a way first to shorten a limb segment and later on to lengthen it to restore these important anatomic formation. طيب احنا الادفانتج ميثود إليزارف ما بنعمل skin incision. The procedure is minimally invasive. Only wires fix the bone to the rings. The Elizarov fixator very versatile. يعني انت بتركب له Elizarov تقول له قوم امشي روح سافر. ما في مشكلة. كمان يستعمل اللمب بنفس اليوم. الكومبليكيشن مثل ما انتم عارفين اكثر شيء اللي هو البن انتراكت انفكشن اراوند ذا كي. لكن هذا اذا كان مايلد انفكشن انتبيوتيكم بتمشي الامور. اذا كان سبير احنا بنغير من تشينج الكي وير. البين اكيد في بين لكن في مسكنات بالبدايه. النيروفاسكولار كومبليكيشن بصير احيانا كونتراكتشر اوف ذا سوفت تيشو انجولار ديفورماتي. ممكن احيانا يكسر بعد ما تشيل الإليزارف. احنا بنقول إليزارف هو زار الأردن 3 مرات وإجا طبعا على المدينة الطبية. عمل عمليات كثيرة بالمدينة بال84 وهو نفسه حكى لي. بس للأسف كمان إليزارب قال إحنا ما عندنا مشكلة نعلم القرد كيف يركب إليزارب، لكن القرد ما بنقدر نعلمه كيف يتعامل مع الكومبليكيشنز. فالعمليات اللي عملها هو شفناها عنده مرة ثانية في كرقان، لأنه ما كان حدا يتابعها. الأهم شيء بإليزارب اللي هي بدك تتابع أنت الحالة. هذا أول جهاز هو استعمله إليزارب قبل ما يستعمل الرينج كامل. الانديكيشن اللي مستعملها احنا having applied many external fixator at the last 13 years، لكن الانديكيشن كانت واضحه اللي هي deformity of the bone، non-unions of long bone، limb lengthening، rotational، neglected hip osteotomy trauma. The history of osteosynthesis suggested that for many years the method used for the treatment of a fracture did not provide the optimal mechanical and biological environment of osseous union. احنا طرقنا كويسة بالأردن إذا بتقارنها بالعالم الآخر، لكن معظم الحوادث اللي بتكون فيها بتكون حوادث يعني فيها بون وسوفت تيشو ودمج وديفورمتي. احنا مثل ما انا بوافق الدكتور زياد، بلا اي او مش دائما الاي او بكونوا الاي او مثل ما انتم عارفين اللي هي الانترنال فيكسيشن اللي هي بليتس وسكروز. اذا صار في كومبليكيشن يعني صار في انفكشن في البليت، طيب غيرنا لانيل وبعدين ما بنقضوا الا الازاره الاكسترنال فيكسيتر اللي هي الاسامي اللي احنا عضو فيها هي الاسوسيشن اوف الازاره. هاي احدى مؤتمراتنا كانت في مصر. نيكست. إذا بدنا نشوف شو السبب، 34% كلوزد فراكتشر و56% اوبن فراكتشر ريزلتد ان بسيردا ارثروزس. ليش بصير عندنا بسيردا ارثروزس؟ مثل ما انتم شايفين ما في جود ريدكشن، في ديستانس بتوين البوند ايدج، في انتربوزيشن، في ايرلي ليم لودينج. هاي بعض الحالات اللي بنشوفها، احنا بنشوف انه في احيانا لانه بكون ويك فيكسيشن، مش معقول هيومرس احط لها كيوير، او مثل ما انتم شايفين هذا اكسترنال فيكسيتر ما في ريدكشن، راح يتحول كله لنون يونيونز. هاي مجموعه مرضاي، انا كنت اشتغلت اول 10 سنين ما اجيت اشتغلت في الزرقاء. هاي مبين علينا لباسنا قديم، انا معهم كنت. هذا هيومرس مثل ما انتم شايفين. شو السبب؟ في سكرو بالفراكتشر سايد. في حالات شديده، على فكره هاي اللي على اليسار دكتور ايمن بالمدينه، لما كنا بالمدينه اجتنا في حالات اذا نيروفاسكولار انتاكت ما في مشكله بالبون، نعمل لينكثينج، بنعمل يعني بضل الوضع احسن. احنا شو بدنا نساوي حتى تريتد البروسيجر؟ احنا بدنا يعني نعمل ريسكشن ريفريشنج للبون ايجز، نعمل ادابتيشن للستيبل كونتاكت، اوبننج المودري كانال، وبنعمل بيرفوريشن احيانا اراوند ذا فراكتشر سايت، وبدنا ريجيد فيكسيشن. هذا اللي على اليسار مثل ما انتم شايفين، يعني هاي الحاله بدناش نقول وين انعملت، بس ما حدا بيقدر يعد كم سكرو. هاي كانت تنتهي بسمبل بإليزارب برينجين وكم كيوير وتنشي. هذول الثلاث صور اللي بحد بعض. الفيمر، هاي فيمر، هاي طبيبة أسنان انعملت. يعني شوفوا، يعني مش معقول إنه 3 بليتات انحطت وهالكم الهائل اللي ما بعرف، يعني ما ضل إشي هيلثي بالبون إلا صار فيه هول، وكلها بضعف الفاسكولارتي. اللي على اليمين كمان في انفكشن. شوفوا وين الصفيحة طالعة وين وين الشباب راحوا. نكست. مش مشكلة، بدنا نكست بس. هاي مثل ما انتم لا نرجع. لا نرجع. ايوه هاي مثل ما انتم شايفين البليت، بس انا بقول لها هي صار لها سنتين هيك البلاد طالعه. كيف عايش؟ قال عايش ولا مشكلة، في التهاب. هذا بايلاترال تيبي بلاتو. مين بيقدر يعد كم كيوير؟ أنا مش قادر يعني. ما في داعي لهالكم الهائل من الكيويرات اللي احيانا كثير احنا بنقول عملنا بليت بيركوتينوس. هاي البيركوتينوس قدامك كيف شايفها. اليزارب برضو اليزارب في اللي يعني اليزارب بده يكون الشخص المعني، بيعرف الدكتور رامي والشباب، بده يكون يعني على علم كيف يتعامل مع الكومبليكيشن. هاي حالة اللي مثل ما انتم شايفينها. شوف بابليتير، هاي في 2 كيور عملن دروب فوت. عندك اللي زارب ما عمره كان يستعمل شانس سكرو على التيبيا او على الفيبولا. هون بحط لك ثلاثة كيوير وبحط 2 شاس سكرو. بتسأله مشان ايش؟ بقول لك مشان الاستابيليتي. لا، مش مشان الاستابيليتي. إذا شايفين هذا حالة شفتها اللي بعدين عدناها. إذا شايفين في 2 هاف رينج من فوق، هذول شايفينهم من فوق ما فيش شيء مؤشر. هذول ما كانوا داخلات بالعظم نهائيا، هذول داخلات بس بالمصل، بالسكن وبالمصل. ولهالسبب كان سيفير بين، كان سيفير بين. اللي على اليمين هاي يعني تو كوركشن وبس، ما بنحط فول رينج على هذا. احنا ما بدنا ننتقد، لكن في حالات يعني بدها إعادة نظر. احنا نفرجيكم كم حالة. هاي حالة كانت ديسلوكيتد انكل مع فراكتشر. هاي احنا بعد ابلايد الى زارب، شايفين الاكس راي، الانكل ريديوزد، والوند اللي كان كبير هيو صغر وهيو تقريبا انتهى. هاي حالة بجوز لو وديناها عم جبر عرب بجوز يظبطها احيانا احسن مننا. تيبر بلاتو مثل ما انتم شايفين. هاي اللي على اليسار اول اوبريشن دبل بليت. بيستاهل هيك حاله يحط لها دبل بليت؟ هاي اللي لازم.
بس هي مش مظبطين.
مش مظبطينها شورت، لانه شوف الفراكشر سايد وين اللي على الفراكشر سايد اخر. كل بليت شورت مثلا. طيب صار انفكشن، شو بده يساوي؟ ايوه تورزيات، شو بده يساوي؟ هيو شال بدهاش عمل. شال البليت اللي ميديالي وحط اكسترنال وخلى اللاترالي. هاي الانفكشن عندك موجوده. احنا اجانا هذا الشكل اللي هو شال كل شيء، رد حط اكسترنال. هذا البيس اوف بون اللي شايفيها دريلينج، هاي كلها سكوستر. احنا شلناها طبعا ونظفنا وحطينا اليزارات. هذا اللي شايفينه هذا سكوستر كله منها. هاي الاند ريزلت. مريض تعالج 4 سنوات وهو يتعذب، روح تعال روح تعال. هذا بيفور وهاي افتر. هاي اللي على الشمال قبل وهاي بعد، والمريض رجع لحياته الطبيعية. هذا شاب عمره كان 21 سنة، وقع بأسانسير حمولة طبعا 7 متر. هسا بتشوفوا هاي الرايت سايد، شايفين البليت اكسبوز. انا اللي اشي احيانا وانت بتودي على البلاستيك سيرجن لما يكون وند كبير ويكون في بليت اكسبوز، يعني ما معقول انه نقدر احنا نعمل بلاستيك سيرجن. هاي الصورة شايفين فيديو هيو بيشتغل ثاني يوم. شو ملاحظين عليه هذا الشاب؟ شو مبين اشي؟ امبوتيتد الليفت. شايف؟ هاي احنا حكينا عنه، بدنا نختصر الوقت. طيب هذا كمان حالة فراكشر فيمر. هذا في نكو فيمر ثبتها بتري سكرو كويس، بس مثل ما انتم شايفين النيل شورت. النيل هذا اللي على اليمين اول ما حطه، هاي بعد فترة. هذا على فكرة تعالج 20 سنة من 2005، من 2005 وهو يتعالج. اجانا بعدين راح على زميل ثاني وعمل له اللي على اليسار البليتس. اذا شايفين البليتس جاب له الانفكشن، ما كان عنده انفكشن، جاب له الانفكشن. اجانا احنا شلنا كل شيء، نظفنا وحطينا له هذا اللي على اليمين اللي زارب. هذا هو، وهاي الاند ريزلت مثل ما انتم شايفين. ورجع بعد 20 سنة مريض موجود. وعلى فكرة والجهاز على الفخذ، مين قال كان في صعوبة؟ كان بيشتغل سايق بأمانة شيء بالغور، يعني ما انقطع عن شغله. هاي حالة مثل ما انتم شايفين اللي هو ديستال تيبيال فراكتشر. كاين اوبن يعني يقول اخف شوي، نحط على الميديال سايد، على الميديال. انا مش عارف اذا بنحط على الميديال كيف بده يضم على بعض مثلا. فنحط الريت على الفيبولا، والكيبولا هذول مش فيكسيشن، يعني هذول ما بتعتبر فيكسيشن. طبعا بعد فتره حط بليت على التيبيا، طب ما هو انفكشن. شايف، حط بليت على التيبيا، اجانا هذا الشكل. احنا طبعا حط جراف انفكشن مثل ما انتم شايفين، يعني شيء. هاي الحالة طبعا احنا حطينا له إليزارا، وهاي الاند ريزلت مثل ما انتم شايفين. مريض من اربد من هون، مش بعيد من هون، عايش عن المستشفى. هذا بيشنت عمره 80 سنة، عمره 80 سنة. لسه انترا ارتيكولار فراكشر يمكن، شايف. فنحط له بليد، دبل بليد. صار في انفكشن، اسف. البيت كان اكسبوز، حطينا له اجزارب within 2 months، سكر الجرحين. احنا احيانا بعرف دكتور رامي نقدر نسكر الوند احيانا، في ننضمه للجهاز ونعمل ابروكسيميشن، لانه ما انعمل جرافت. هذا شايفينه التو وند الكبار ما عملنا له جرافت، سكر لحال. وهاي الحكي عايش. طيب 80 سنة، خليه يعيش كم سنة ومع السلامة، شو ما صار يصير. أما تجيب له انفكشن وتجيب له جرح، وكان يعني كان الختيار مسكين، يعني صعب التعامل معه. هاي الجرحين without skin graft، ما في skin graft، يعني أموره مشت وقام وبمشي طبعا، وبالعلاج الطبيعي فول رينج. هذا انذر بيشنت مثل ما انتم شايفين، انعمل له بليت وصار في انفكشن. يعني احيانا احنا وفي ديفورماتي بالانكل، بنحب احيانا البليتات ونحب هيو. احنا على اليمين شلنا طبعا البليت كله، نظفنا، وهذا اليزار. هاي اللي على الشمال اللي هي الاند ريزلت. هذا هو قبل ما نعمل له. هاي بعيادتي. هذا نفس الشيء، يعني بعد ابلايد اليزارا. وهاي الاند ريزلت. دكتور مصطفى البوريني بجوز شافوا هذا، لانه كان عندنا الدكتور مصطفى وقتها. هذا كمان حاله نون يونيونز وانفكتد نون يونيونز. هذا مثل ما انتم شايفين الصورتين، هو كان بايلاترال اكسترنال فيكسيتر. اذا ملاحظين بالهيل بالكالكينيوس كان بجوز طولها نص متر الشانس سكرو. كيف بده يمشي هذا؟ مش راح يمشي. فكان شهرين وهو نايم على ظهره ما يقدر يمشي. فاحنا شلنا له كل هذا وركبنا اليزارب وبلشنا نعالج بالوند. هاي بلش يصغر الوند. هاي اليمين، هاي الشمال، وهاي اليمين قبل وبعد. هذا المريض. وين راح الشباب؟ مشي مشي هذا بس الفيديو. هذا برضه بايلاترال إزارة كويس، وكان يروح ويجي ويشتغل. الثاني هذا بعد ما شلنا الجهاز. طبعا علاجه كان 6 شهور لأنه بايلاترال مع بعض. هذا مثل ما انتم شايفين نان يونيون فيمر، وشايفين رايح باكسترنال، رايح وصار عنده شورتنينج 4 سم. فشو احنا بدنا نحل مشكلته كلها، نان يونيونز، شورتنينج، وروتيشن. احنا عملنا كومبريشن من فوق، وعملنا اوستوتومي مشان نعوض اوفر ذا نيل. النيل سبب النون يونز اللي عنده ما كان مثبت النيل من تحت بسكرو، بس مش قادر الجراح يحطهم، فقال لك خلص بتمشي. فاحنا استعملنا النيل، استعملنا نفس النيل وعملنا استوتومي وبلشنا نطول. طولنا ومشت اموره وعدلنا الديفورمتي. هذا مريض برضه مهندس كان عمره 48 سنة، RTA طبعا، انعمل له على الليفت وعلى الرايت. حلوة الصور، حلوة، شو مالها؟ طيب كويس، ليش بنعترض؟ احنا ما بنعترض على الاي او هي الاساس. هاي الليفت، هاي الليفت وهاي الرايت. هاي الليفت، هاي اذا شو لو حطينا الكمبيوتر بدي هاي فيديو. طيب يعني الجهتين انفكشن، الجهتين البليت اكسبوز. شايف؟ طيب شو بدنا نسوي له؟ هذا تودع على البلاستيك على اساس يعملوا له سكين جرافت، وقعد بلاستيك اكثر من شهرين، ما بنعمل البلاستيك. نكست. هذا احنا عملنا له طبعا نظفنا وشلنا كل شيء، ونظفنا ركبنا بايلت. هاي صورة المريض، هذا المريض فيديو هيو بيمشي. موضوع انه بتر اجريه ثنتين مش وحده، بتر اجريه ثنتين. كان موافق هو، بعدين قالوا له هاي حالة تخدرت. دكتور أحمد هاي عندكم ها، تخدرت بحدود 30 مرة. شايف؟ فاجتنا بهذا الشكل انفكتد، وكانت بدها تنتحر حتى. فاحنا شلنا كل شيء وركبناها الى زهره. هاي لحمت، عملنا لها ارثوديدس، لحمت تماما. بس رجعت بعد فتره. نكس والله. هاي مشت، هاي مشت بعد فتره، رجعت قالت لا انا بعرج، ترى لابسه حذاء 5 سم، اذا شايفين حذاء 5 سم بالرايت سايد. فقالت لا بدي اطول حالي، فرجعت وعملنا لها اوستومي مثل ما انتم شايفين، وطولناها 5 سم ومشت ورجعت. هاي فيديو. وهايها بتمشي، تمشي كويسه ومبسوطه وعايشه حياتها. بعديها نكست. هذا حالي، لا نرجع. هذا حالي نفس الشيء، نيونون انفكتد، وكان البون اكسبوز مثل ما انتم شايفين. نكست. هذا احنا الاكس راي مش مبينه برضه، يعني بروسيجر نفسها. هاي الفيديو هاي بنفسه بعيادتي، هذا كومبليت هيل، ومشى ورجع لشغله. رجع. هاي حالة انذر كيس اللي هو انفكتد نون يونيون 31 سنة. هذا الفراكتشر. هذا احنا اثناء العلاج. هاي الاند ريزلت بعدها. هاي الاند ريزلت، نو انفكشن واموره كويسة. هايو بمشي. ايوه. هذا سوداني اجى. هذا المشكلة جاء من السودان، اجى على عيادتي بيقول لي انت حمد لي قرش؟ قلت له اه. قال لي جاي اتعالج عندك؟ قلت له اهلا وسهلا. قال بس ما معي قروش. قلت له كيف؟ قلت له كيف جاي ما معك؟ قال انتم ما عندكم لله؟ قلت له ايش؟ عندنا لله. قال انت بدك تعمل انت عالجت واحد بيعرفه من السودان وهو دوب، بدك تعالجني ببلاش. فكرت قلت شو بدي اسوي؟ طيب ادفع ايجار المستشفى. قال ما معي قروش نهائيا. رحت على مدير المستشفى قلت له في سوداني هيك هيك، انا اجرتي سامح فيها. قال لا المستشفى بدك تدفع، بس بنعمل خصم. عمل خصم وعالجناه وكل شيء. اجى يروح ولا هو جاي يقول لي كمل معروفه. قلت له شو؟ قال بدي $200 اشتري هدايا لاخواني. والله العظيم. قلت له شو رايك اجوزك كمان؟ قال لا جيزي مش عايز. المهم اعطيناه مثل ما قال. بس بالله العظيم يا شباب وداني اكثر من 10 حالات. صار يلف هناك، كل ما يشوف واحد بعرج يقول له روح عند فلان. هذا بعدني بتذكر. رحت على السودان، ضل يدور علي يومين بعد ما سافرت، بذبح لي بقره. هذا هو بيمشي غيره. هذا دكتور جعمان. هاي لو بدنا نقصرها، هذا جوزها على فكره. احنا مبسوطين انه صار بالقاعه شوي. يعني بقول لك how important is the high for the particular person to feel completely. How sure are you in what you are doing when breaking healthy adult leg to make them longer. يعني شو بدك تطول فيها بتيسرها مسكين. هذا حالي كمان اجتنا نانيونز مثل ما انتم شايفين، سيجمنتال، في بالالبو وفي بالمتش. يعني شو بدنا نحط لها؟ دبل بليت، ما هو اوبن فراكشر. احنا حطينا لها، نظفنا وحطينا اليزارم. احيانا بنحط انترا مودولار نيل مشان تو كيب الاينمنت. هيها لحمت والالبو لحمت وممتازه. هاي انذر كيس اجانا برضو اي RTA مثل ما انتم شايفين، و اوبن فراكشر. شو بدك تعمل له؟ احنا هاي الصورة قبل كاين في عنده فراكتشر قديم. هاي فيديو. يعني احنا شلنا الصفائح لا اللي قبلها. يعني ما معقول مثل هيك انك تفتح وتحط مثل، اكيد بده يصير في انفكشن اكثر وصعب نخلص منه. بعدين للوند اصلا ايزي انه احنا نغير دائما ويكون مرفوع بعيد، يعني ما بنقدر نحط له جبصيني ولا نقدر نحط له شغله. هاي الاند ريزلت. هاي بالله فيديو. هاي without skin graft، كله مشى بدون سكين جرافت هذا الشغل. المشكله بعد ما شفي ب3 شهور اجى على المستشفى نكو فيمر، قلت له انت مستلمنا هسه. هاي الاند ريزلت. هاي انذر كيس مثل ما انتم شايفين نون يونيون. شو مع دكتور حمزه انه نحط له بليت ولا شو بدنا نحط له؟ شو رايك انت؟
يعني هذا بدك تحط له ديستال ال سي بي
ديستال على هيومرس والبوث بون هون
والبوث بول برضه كمان ال سي بي.
ابدا هيك. طيب شوف شو زميلنا شو حط له. كويس.
اكس فيكس
اكس كويس.
كويس بس مش مرجعه.
وين كويس يا زلمه؟ هذا
مش مرجعه.
مش مرجع. ممكن يصير هيلينج.
لا طبعا.
طيب روح على الباقي. طيب هذا شو على اليمين؟ اوبن كان. مش معقول انه انت تحط له شيء داخلي. حطينا له اللي زارق. هيو على هيومرس وعلى الفور ارم. نكست. هيو كومبليت هيلينج والوند برضه without graft. نكست. هذا بدنا
فيديو.
بيجينا احيانا حالات مثل هيك. شايف شو بدك تسوي فيه يعني. وعايش ومبسوط. كيف والله أنا عارف. لو شفت بطنه كيف وجري. نكس. هاي في حالات كمان، لا قبل. هاي في حالات كمان يعني تقشعر لها الابدان. حجه بتلف ايدها 360 درجه مش ماشي شيء، بتقول بنام هي على اليسار بس حوله هي تحتيه. شايف. نكس. هاي الحاله وين راح دكتور احمد؟ هاي الحالة برضو هاي بيجوا والله مثل ما انتم شايفين سيجمنتد. يعني هذول السكرو اثنين المحطوطات فوق على الفراكشر، هل هن ماسكات الفراكشر؟ والريدكشن على اللترال فيو شايفين. يعني هذا سايق شاحنة على فكرة فعلا مش هذا. خلينا نشجع الدكتور ايمن هسه. شو نقول. هذا انعملت هون، هذا سايق شاحنة. اسف طيب. طيب. طيب هاي اليمين، هو اليسار واليمين الثنتين. خلينا اعطينا دقيقتين اذا من الصبح عن لسه. طيب هذا المريض، هي المريض بيمشي بعد هيك كسور. هاي دكتور ايمن. هاي يا سيدي هي وبمشي ما في مشكله. يلا دكتور أحمد. طيب هاي حاله، نرجع لورا شوي. نرجع. هاي حالة تعالجت على اساس انها فراكشر، هي نيروفيبروماتوزس، فنحط لها صفيحتين صار في انفكشن. طيب هاي ذاب المفصل اجانا هيك. شايف احنا هاي كومبليت هيلينج كويس. هاي هو بالعلاج. هاي هو بدون الجهاز. نكسر. يعني دكتور وين راح دكتور رامي؟ يعني هاي بحاجة لتطويل. هاي بدهاش تكسر، بدها تطول حالها. شو خاصة طولت. هاي الحالة آخر حالة مثل ما أنتم شايفين أو قبل آخر حالة. هذا شوفوا كيف الديفورماتي عندها. وهاي الفكر شو تتوقع دكتور حمزة؟ هذا RTA ولا إيش؟
اتوقع شيء نيورولوجيكال.
شيء نيورولوجيكال. طيب. السبب إيش؟ هاي السبب قرصة حية، هي من اليمن. قرصة حية. هاي أثناء وإحنا نشتغل. طيب بعديها هذول علاج طبيعي مرضانا كلهم بيشتغلوا. بعديها في حالات كمان كثيرة دمج هون. هذا شايف أهم شيء الكلب هذا عالجناه كويس وضعه، شكله حلو كمان. مع ارتفاع البنزين باعتقادي راح نحول احنا نصير نختصر شوي بالبنزين. طيب هون بقول لك مشان الله لا تكثروا براغي. هاي حالة بس آخر حالة دكتور زياد، هاي مثل ما أنتم شايفين إجانا نانيون. هذا مثبت شهرين بهذا الشكل. أنت تصور مثبت الليج ومثبت الفيمر ومثبت الحوض، فكيف بده يقلب على جنبه؟ هذا الوند اللي اجانا في من الخلف. هذول البنات اللي شايفينهن هارد كريست مبين، هذول بالابدومن. انا متحس يعني متحير كيف ما عملناش في مشكله. هاي احنا بعد ما شلنا وعالجنا الجرح ركب. هاي على اليسار كومبليت هيلينج، يعني هو شهرين ما بقلب لا على ظهره ولا على جنبه الثاني، ومبسوط ومشت اموره. احيانا الازاره بكون اخف كثير. هاي اخر حاله بدنا رايكم فيها. هاي بليت صار في انفكشن، نحط له اللي على اليسار هذا نحط له نيل، ونحط له الازاره بس انا كلينيك، نحط له الازاره. اجانا بالصوره هاي اللي هون، حكينا له شو لازم تيجي. راح على زميل ثاني قال له لا انا بعمل لك هيك، فعمل له هيك وصار له 4 اشهر. بقول له راح يصير في هيلينج. يصير هيلينج هيك. هاي حاله برضه انترا ارتيكولار بليت. هاي انعمل له اليزاره بس مش عندنا. هذا اللي شايفينه عمل يعني ريزكشن وشال جزء كبير من العظم وحط له سمنت، واخر شيء انبترت رجله. هاي مجموعه مرضانا. هذا كنا في سان بطرسبورغ، المرضى اللي تبعين الحرب الاوكرانيه كلهم بتعالجوا باليزاره. هذا اليزاره مثل ما انتم شايفين، وانا هذاك المسكين اللي قاعد اخر شيء اذا شايفين. هذا زمن الشباب مثل ما بيحكوا. احنا اخذنا اللي هي البروفيسور الفخريه، انعطت ل20 واحد بالعالم، انا واحد منهم، لانهم بيعرفوا. وباعتقادي هذا التمثال بسوى الزارب انه ينعمل له تمثال. وهذا قبره اللي كل يوم بحطوا له ورد، وهذا بيستعمل الجهاز. وشكرا. تمام. شكرا.
سويتش على البرنامج راح يضيف لنا النكست سبيكر اللي هو الدكتور يزن علاقه. يزن يو ريبورتنج سيرجن. الان هو في الصحه. ايش؟
دكتور ايش محاضرة اسمه؟ اللي موجود معنا. بس السلام عليكم. Today I will present a case which evolved in a way that challenged both our diagnostic assumptions and management strategy. I will walk you through the case as it unfolds, because the real value of the case lies in the sequence of decisions and the uncertainty that followed. Our patient was a 25-year-old female
who presented with a 3-month history of progressive low back pain radiating to the right lower limb. Her pain was severe enough to interfere with her ability to walk and stand. She reported no systemic symptoms, and on examination, she showed she had marked weakness on right ankle and toe dorsiflexion, graded 1 out of 5, along with sensory loss over the L4 and L5 dermatomes. Her laboratory workup was unremarkable. So we did an MRI, and as you can see, there is a complete collapse of the L5 vertebral body, along with a soft tissue mass causing near complete obliteration of the spinal canal. Given the symptom severity and the presence of a neurological compromise, the patient was started immediately on dexamethasone while a biopsy being arranged. What was remarkable is that after a few days after steroid initiation, the patient showed a remarkable clinical and radiological clinical improvements. At that point, we performed a new MRI, which showed a striking decrease in the soft tissue component of the mass, as you can notice in figure B. Now I would like to ask you, when a spinal lesion shows such a response to steroid, what diagnosis comes to mind first? Osteoid osteoma ما يكونش في soft tissue component زي steroids. دكتور زياد.
Usually يعني lymphoma will يعني show
response to steroids, such a response.
And will know to respond to
steroids,
and it's part of the treatment also.
And that what was our presumed diagnosis, and we actually started to discuss the treatment plan with the oncologist. But the biopsy did not fit our presumed diagnosis, as it was reported as giant cell tumor of the bone. So how would we be able to interpret a lesion that behaved like a lymphoma radiologically, but reported as giant cell tumor? Could the sample have been inadequate or crushed? Could steroid exposure before biopsy have altered the tissue appearance? Could it be a pathologist interpretation error? And is it usual for giant cell tumor to have such response to steroid? And based on the answers to these questions, a stepwise plan was established. So the steroids were stopped, since they can alter the histopathological picture, especially in cases of lymphoma. A repeat biopsy was arranged with multiple samples. The biopsy material was reviewed by multiple pathologists at 2 different centers. We also reviewed the literature and found only a very limited reporting of similar response. Most of these reports discussed cases of secondary giant cell tumor in patients with Paget disease. While we wait for the new biopsy result, the patient experienced symptom recurrence, and a new MRI showed regrowth of the mass to nearly its original size. هاي الصورة بعد ما وقفنا الاستيرويد للمرة الثانية. The repeated biopsy again confirmed giant cell tumor. Therefore, our diagnosis was no longer in doubt. We discussed the management options. Denosumab was considered, but it was not available at that time. Therefore, the patient underwent posterior L5 corpectomy with wide decompression, cage reconstruction, and iliolumbar instrumented diffusion. Post-operatively, she improved and regained mobility. And the final pathology again confirmed a giant cell tumor of the bone. So we proceeded with surgery, achieved decompression, and finally had our definitive diagnosis. But one question remained unresolved: was the steroid response a real biological effect or just edema reduction? Unfortunately, we didn't have to wait long to face that question again, as the patient in less than 2 months experienced tumor recurrence, and a new MRI show severe canal compromise. Severe canal compromise. We were then in a difficult situation, either to perform a high risk reoperation or to consider denosumab, which was not available yet. So we started the patient on steroid again, as we thought it might produce a response as it did previously. So when we started the patient again on steroid, it showed a remarkable response, and the patient rapidly improved clinically and radiologically. So we maintained the patient on oral steroid for 6 months until the denosumab became available. Then, and these are her MRI at 3 years follow-up, and there was no further progression, and the patient condition is stable. Take-home messages: an unusual steroid response does not automatically exclude giant cell tumor of the bone. Steroid may have a temporary bridging role in selected spinal giant cell tumor, but definitive disease control still depends on standard treatment. Preoperative steroid-induced tumor shrinkage may potentially improve surgical resectability and lower recurrence rate, but this hypothesis requires further investigation. Thank you. في طبعا هاي اول كيس ريبورت، يعني احنا بالليترشر ريفيو ما في ولا كيس زيها، يعني الكيس الوحيد اللي برايمري جاينت سيل تيومر ريسبوندينج للستيرويد لا راديولوجيكلي دوكيومنتد، والفاينل هيستوباثولوجي اصلا ما فيها جاينت سيلز، فهي هاي اول كيس ريبورت، يعني ان شاء الله شهر تكون طبشت.
هي is always challenging. It's benign, but it's very appropriate, and usually it involves the articular surface. So I was thinking, when we observe this, even in the femur, it's the femur of your more common location. So it's, if the articular surface is severely involved, you might extend this. You might treat him equally, they are young female. So steroid might be an option to start. Mix it with denosumab, help with the before surgery. So it might give you an insight. يعني مرات الكلينيكال يعني usually يعني young it's good to know this.